So I think we're going to get started with the last session for today. And just in case you are here at the Medical Perspectives on International Adoption, and I'm just going to briefly introduce our two speakers for this session, which are Dr. Dana Johnson from University of Minnesota and Dr. Laurie Miller from Tufts University School of Medicine. So first, Dr. Johnson is a professor of pediatrics and members of the divisions of neonatology and global pediatrics at the University of Minnesota Medical School. And it's also at University of Minnesota that he co-founded the International Adoption Program in 1986. His research interests include effects of early institutionalization on growth and development and the outcomes on internationally adopted children, which we'll hear more about today. And he is a senior research fellow in the Evan B. Donaldson Adoption Institute, and he currently serves on several editorial boards and has authored over 200 scholarly works, and he's received several awards, such as Distinguished Service Award from the Joint Council from International Children's Services, and the Harry Holt Award from the Holt International. And he also serves on the boards of directors of Joint Council on American Council on Adopted, or the Joint Council on International Children's Services, and several other foundations. And then we also have Dr. Laurie Miller from Tufts University in Boston. And Dr. Miller founded the International Adoption Clinics at Tufts Medical Center in 1988, and she's also a senior fellow in the Evan B. Donaldson Adoption Institute. She's served as a pediatric consultant in more than 10 countries. She's done a lot of international work, so she oversaw an NIH-funded program to improve outcomes for orphanage residents in Russia for many years, and she's established the Big Sisters projects in baby homes in Russia, Ukraine, and India. And currently she serves on the NIH study section for brain disorders in the developing world, and she's currently the principal investigator of a longitudinal project to monitor and improve the health and nutritional status of impoverished children in Nepal. And she's also published several peer-reviewed articles and written many chapters, and as well as 2 books. And she's also a board-certified pediatric rheumatologist and directs the pediatric rheumatology training program at Tufts Medical Center. So we have very great speakers here today, and I just want you to welcome them.
Thank you, Yesel. It's nice to be here, and welcome to this session on medical perspectives in international adoption. We're going to talk about adolescent growth, health, and development. It's a real privilege and an honor to be here, and a pleasure to see so many friends, colleagues, and families. It's just great to see everybody. I'm really happy that the organizers decided to include a session on medical issues. I think Dana would join me in endorsing the statement that awareness of medical problems is critical to understanding the well-being of children. And if we don't know about the health issues, everything else can be a little confusing. And these systems interact in many ways, which we're going to try to touch on today in our presentations. I'm going to tackle the basic medical or health issues, and some of what I'm going to present has to do not only with the population of internationally adopted children, but also other populations of teenagers. And then Dana is going to take on the task of describing to you some of the complexities related to growth and catch-up growth. And I'm really looking forward to hearing an update on his very exciting and innovative research in this area. So I think we're going to enjoy this session this afternoon. Now, before we start talking about adolescence, we have to step back and look at the information on this slide, which tells us who are these adolescents. This is data derived from our clinic population over the last X number of years. I don't want to say how many, it's kind of been a long time, but you can see that the children that we're talking about as teenagers came mostly as young children. So nearly 3/4 of them arrived less than 2 years of age. So that's the population to keep in mind when we're talking about health issues in internationally adopted adolescents. The reason that's important is because what we're going to look at is the late effects of various medical conditions. And these can be conditions that were previously diagnosed or were overlooked. We certainly hope that all children have the recommended screening test for internationally adopted children that was first defined by Dana and his colleague Peggy Hostetter a long time ago, published in Pediatrics and then in the New England Journal, and that has really served as the model for this screening for new arrivals. But unfortunately, that doesn't always happen, or it's done incompletely or incorrectly. Regardless of which pathway these children have followed in terms of their health issues, the characteristics of the conditions that I'm going to be describing today include those that have a progression of symptoms over time and tend to have a very long latency before clinical manifestations become apparent. Now, this slide shows the list of the health issues that I'm going to be describing to you: infectious diseases, toxins, prenatal exposures, genetics, a couple of random medical conditions, and then a little bit on functional outcomes at the end. So there's a lot to cover, and I'm going to go kind of fast through this. We're going to start by talking about some of the infectious diseases that I think are important when we're discussing health of internationally adopted teenagers. Let's start by looking at parasites, and the parasites listed as a model of infectious diseases. The infectious diseases listed on this slide all share the characteristic of a long latency. Now, any of the conditions listed here can present acutely shortly after the infection occurs, but these particular conditions have the additional characteristic of perhaps presenting at a later date, months, years, or decades after the infection occurs. So we'll start with parasites as the beginning. Now, I think most of you know that parasites are organisms that live in the intestinal tract or in other sites, and about 50% of new arrivals have parasites. It's much higher in the kids that we're seeing these days from Ethiopia and other parts of Africa. When the kids arrive and they have the parasite infections, the symptoms are variable. A large number of them may be asymptomatic, but we often see kids who have GI problems of various kinds, poor growth. Some of them may have irritability or behavior problems. Now, the irritability behavior problems sometimes is not obviously linked to the parasites, and the connection of cause and effect is made later after the parasites are identified and treated. And there may be other late problems with parasites. I hate to show this slide because you just had lunch not that long ago, but this is an example of a worm, an intestinal parasite, that was coughed up at the Thanksgiving dinner table by a child who'd been home for 4 years. And this child's mom was one of the moms who was particularly worried about her child having parasites. So she did not the 1 or 2 or 3 samples that we usually recommend, but she did 6 stool samples, and they were all negative. And yet this parasite was present in the child and had been missed for all of those years. Now, in addition to the gastrointestinal problem that a child may have with a belly full of these worms, there are other important medical and other problems that can occur in this kind of situation. And you might be surprised to learn that parasite infections can have an effect on cognition. And this is particularly alarming when we think that there may be a lot of kids out there with occult parasite infections. On this slide, you can see the increase in likelihood of, oops, that was bad. What did I do wrong here? Help, someone. What did I do? I thought this was the pointer. Come back. Thank you. Which is the pointer then? This one. That's the laser, that's what I want. Okay, good. All right. This is the increase in likelihood of poor performance on various neurocognitive tests in kids who were infected with Ascaris, shown in blue. That's the worm I just showed you, or hookworm, shown in red. And you can see that the increase in likelihood of this poor performance ranged from 1.5 to 3.5-fold increase in the kids who had these parasite infections. Now, this is another example of a late effect of a parasite that can be an occult parasite. And this obvious brain lesion is the result of a condition called neurocysticercosis. That's not important to remember, but this is a manifestation of a certain type of tapeworm infection. I want to point out the two citations that are on this slide here, because both of these are case reports describing internationally adopted children with unrecognized neurocysticercosis. In the first case, the child presented with seizures, hallucinations, and behavior problems that lasted for many, many, many years before this condition was properly diagnosed. And the only information in the case report is that the child came from a war-torn third world country. So I don't know where this child came from. The second case report describes a child who presented with all the symptoms of a brain tumor and went to the operating room, had a brain biopsy, and everyone was shocked that the sample came back showing this condition, neurocysticercosis, instead of a brain tumor as everyone expected. The case report is very odd in its wording because in the description it says the child was admitted with an Anglo-American surname, and then later on in the case report they said it was revealed that she was Korean. So it's really important to remember that kids may come with problems from their birth country, and people really forget about this as time goes by. Let's next talk about tuberculosis. Tuberculosis is diagnosed in a latent form in about 15 to 30% of children coming at arrival, and the highest risk children are those who come from Russia and Ukraine. Now, latent TB is important for many reasons, the most important of which is that it can activate, and activation can happen at any time. The most illustrative and scary case that I know of is a description of this 9-year-old boy who was adopted from the Marshall Islands and was living in a very, very small town in North Dakota. And before his TB was diagnosed, he managed to infect 56 people in this small town and expose an additional 118 people. There was a 2-year delay in diagnosis from the time he arrived in his adoptive home to the time the TB was diagnosed. So that's a lot of exposures, and you can imagine how that family felt about having been the vector for this very serious infection in their small town. This slide shows the percent of foreign-born individuals with TB by the time of residence in the U.S. prior to diagnosis, and the data is from the CDC. This is not adoption, this is just foreign-born residents in the U.S., and you can see that about 65% of cases of TB in migrants present more than 5 years after arrival. So this TB is kind of a reservoir waiting to explode. Because of data like this, I'm really anxious every morning when I open the Boston Globe because I dread the day when I'm going to see one of my patients' names in one of these headlines, like the headlines you see here, an immigrant child in Sweden exposing 261 students, or this terrible case that we had in the Boston area of a surgical resident in the Boston hospitals exposing more than 3,700 people, patients and coworkers, to TB in 4 hospitals over 6 months. Now, neither of these individuals were internationally adopted, but they could have been, and it's very likely that that may happen, and we'll be reading more of these kinds of cases as time goes on. This is underlined by a very important paper that was published from Mary Statt at the Cincinnati Children's Hospital. She methodically looked at this in a very interesting way. She did a second TB test in children who had had a negative TB test at arrival and found that 20% of this group had positive TB tests. Without that second TB test, 20% of children with latent TB would have been missed. So that's really an important lesson to all of us, to test and then test again. And this doesn't always happen despite our recommendations to do this for many years. Just as a footnote to the TB story, I think all of you are familiar with the concept of multiple drug-resistant TB, or MDR TB. And again, foreign-born individuals are the reservoir for this in our country, accounting for 73% of MDR TB. And there are certainly going to be some internationally adopted children who are bringing MDR TB to our country. Now, let's move on to hepatitis B, another disease of potential long latency. And this slide shows the global prevalence of hepatitis B infection. You can see in the darker colors, everything looks dark, sorry about that. You can see in the darker shades here the countries with a high prevalence of hepatitis B, and many of these are countries of origin for international adoption. Now, about 4% of children come to the U.S. with unexpected positive hepatitis B testing. These children had negative tests in their homeland country. When they get here, the tests are positive. And there are a lot of complicated reasons for that, but suffice it to say at this moment that unsterile needles are used in 30 to 75% of injections in the developing world. And sad to say, but international adoptees account for 1/3 of hepatitis B infection in young children, according to the statistics at the CDC. Now, what happens with hepatitis B? It's kind of embarrassing to say this, but a lot of pediatricians do not know the right tests to order. They know they're supposed to check for hepatitis B, but if they look at the lab slip, there's a bunch of them on there. And more often than I would like, the wrong one gets checked off. And so somebody may think they've checked for Hep B, but they really haven't done the right test. Another situation is somebody who's known to have hepatitis B and then has this progression of symptoms over time. This next slide summarizes some of the outcomes that might occur in either one of these situations. Chronic hepatitis B in young teens and young adults. And I've summarized just a couple of studies that show follow-ups ranging from 8 to 23 years, and you can see the percent of individuals who develop cirrhosis, which is a very dreaded complication of this infection, ranging from about 3 to as much as 28%. And of course, these were very different populations, but it's a real problem for these individuals. Also note that some of these individuals have the increased risk for liver cancer. This slide compares common cancers in the developed versus developing world. And the more developed countries are shown here in red, and the less developed countries are shown here in blue. I've highlighted liver cancer here because hepatitis B is very closely associated with the risk of liver cancer. It's one of the strong connections as a viral cause for a form of cancer. And you can see that in less developed countries, the risk is about 132 per 100,000 versus 33 in the more developed countries. And this is all attributable to hepatitis B, virtually all, not completely, but most of it. Let's move on and talk about one that really is one of my pet peeves, and this is Helicobacter pylori, if you've heard of that germ. It's an intestinal bacteria that causes a number of problems. And on this slide, you see the prevalence of H. pylori infection in developed versus developing countries, and you can see there's quite a difference there. 41% of international adoptees come home with H. pylori infection. The infection is associated with older age at arrival, orphanage residence, Russian orphanage, or co-infection with Giardia, which is another parasite that might be more familiar to you. A recent consensus statement that was published in the Canadian Journal of Gastroenterology stated that Helicobacter pylori is a World Health Organization Class 1 carcinogen, and in addition is also associated with non-malignant gastrointestinal diseases, and that all persons with H. pylori infection should receive treatment. Again, here's the comparison of cancers in more and less developed countries. The relationship of H. pylori to gastric cancer or stomach cancer is very close, and you can see 192 here compared to 125 there. Sad to say, but even treatment of H. pylori does not always eliminate this risk completely. And in this study, 28 of more than 1,600 patients developed gastric cancer even after treatment, as long as 13 years after eradication of this infection. Now, if it's not bad enough to have stomach cancer, ulcers, and other non-malignant gastrointestinal problems, there's some interesting data saying that H. pylori is associated with cognitive deficits, and that is demonstrated on this slide, where decreases in full-scale nonverbal and verbal IQ scores were found in kids infected with H. pylori compared to non-infected controls. Let's move on to syphilis. About 5 to 10% of Russian and Eastern European referrals have a history of congenital or maternal syphilis. And this is occasionally seen from other countries, but rather seldom. And in general, most of the sending countries do quite a fine job of diagnosing and treating congenital syphilis. But every once in a while, there's going to be a child who slips through, doesn't get diagnosed in the birth country, and doesn't get diagnosed here because the recommended screening tests are not done. Syphilis, of course, can come from sexual abuse, but I want to focus specifically on congenital syphilis if it's undiagnosed and untreated in infancy. What happens? Well, if somebody's really alert, they're going to notice that the individual may have these unusual appearing teeth, but that may also be missed. And someone can get to adulthood and develop blindness from keratitis, which is an inflammation of the cornea. This is untreated congenital syphilis, or deafness, as this individual developed as an adult, having had this infection his entire life without a proper diagnosis. Last infectious disease to talk about is HIV. And although we get very, very few kids with unexpected HIV infection coming for international adoption, there are increasing numbers of HIV-positive children coming to our clinics. Most of these kids do very well. They're well managed, they're thriving, they're growing, they have a chronic medical condition, and they're doing quite fine. However, teenagers may be at increased risk of some of the problems shown on this slide, either due to activation of the HIV infection or complications of the medications. Let's move on and talk about toxins. I'm just going to describe the effect of two toxins, first of all, lead, and secondly, radiation. Lead poisoning, as you know, is a common problem in our own country, and lead is a very potent neurotoxin. About 2 to 3% of international adoptees come with elevated lead levels. This number at one time was much higher from China, as high as 14%, but the number seems to have dwindled down considerably. Now, it's important to recognize that kids with lead toxicity in early infancy may be completely asymptomatic, but even if they are recognized, treated appropriately, they still may have consequences of this intoxication later on in life. And there's tons of data that talks about the medical complications of lead poisoning in early life. And I've listed them here. They include all kinds of behavioral problems, learning problems, and psychiatric problems. So this is a consequence of lead exposure in early life. Now let's move on to radiation, because many families ask about this and wonder about this because they've adopted kids from Russia or Ukraine and are worried about radiation exposure there, or even in other locations as well. And the concern with radiation exposure is the development of thyroid neoplasms, particularly thyroid cancer. This slide shows the time of latency to the development of thyroid cancer, and it's very, very long. It's about 30 years, as you see over here, as an average, but there's quite a big range. And over here in red, I've highlighted a very important subgroup of this population, which is individuals who are exposed at Chernobyl. It seems that the latency is much shorter in that group, and only about 8 years. Now, I have not seen any kids from our own practice that have thyroid problems from exposures at Chernobyl, and I haven't seen it reported anywhere, but I think it's just a matter of time before something shows up in the literature about this. I next want to move on to prenatal exposures, and a lot of the other speakers have addressed this or alluded to this, so I'm just going to give kind of a bird's eye view because there's some common themes that you've heard already today, but I want to emphasize them in the context of health. First of all, we need to understand how frequent these exposures might be, and there's not a lot of really solid data on that. This is from a study we were able to do in Russia, where we were allowed, amazingly, to look at the medical records of the birth mothers of children who were living in the baby homes. And it was quite a large number of medical records that we were able to review, and we found that there was documentation of alcohol use and tobacco use in about 40% of these moms during the pregnancy. So you can guess that the number actually was much higher than that. Drug use was documented in about 7%. So what are the common themes? Well, adverse prenatal exposures of this type tend to lead to problems with regulation of attention, learning disabilities, and behavior problems. And that's a simplistic approach, but it just gives you the general overview. And then if we talk about some of these exposures specifically, we can learn a little bit more. Let's start with the prenatal exposure to alcohol and what that might look like in a teenager who had this exposure before birth. The areas that are affected are listed here and include a wide array of problems. But perhaps more important than these problems is the lack of diagnosis that many of these individuals experience. Unfortunately, again, pediatricians are not well educated to recognize the phenotypic changes that are typical of this condition, and really the only way that we can legitimately make this diagnosis when we don't have accurate information about birth mother exposures during the pregnancy. And it's important for this diagnosis to be made because treatments and interventions may be different for a fetal alcohol exposed child, and it may be important to have that information when planning is done for educational or other purposes. What about prenatal exposure to tobacco? There's data that shows increases in all of these different areas, including an interesting suggestion of early puberty in males, and reduction in head circumference and IQ after tobacco exposure prenatally. Prenatal exposure to marijuana, decreases in school achievement, executive function, visual processing, and increases in ADHD, and some suggestion of increase in substance abuse, marijuana and tobacco specifically. Cocaine, again, increases in ADHD, externalizing behaviors, substance use, and high-risk behaviors, and decreases in perceptual reasoning. These are just synthesized from a number of studies, and I can supply references for each of these if you're interested. And there's also some interesting study on brain imaging in teenagers. We saw some beautiful images of the brain developing this morning, and cocaine exposure prenatally can show up as abnormal brain appearance in a teenager. So even that many years later, there's some still structural problems, specifically reductions in particular regions of the brain or increases in other regions of the brain. Prenatal exposure to opiates, there's evidence for decreased cognitive function in the teens and increase in behavior problems in ADHD. And I want to emphasize that this data is not talking about adoption. As Professor Gunner said this morning, we have to look at the other literature that tells us about what's going on, because that's applicable to this population. This is not an adoption-related phenomenon. This is just limiting to the exposures and other concurrent risks that may go along with that. I want to move on to talk about genetics and show you this slide, which lists some of the mental health disorders that have been strongly associated with a genetic component. And on the left-hand side of the slide, you see all these different disorders, and on the right-hand slide, examples of each of these disorders. All of these have strong data suggesting a genetic component. And all of them, except for the memory and Alzheimer's disease, may present in teenagers. So there's certainly the risk for a genetic piece when we see these kinds of conditions develop in our teenage kids. This was well introduced by Professor Gunner's description of epigenetics this morning. I'm so grateful to you for describing that so clearly. But I want to show you some specific examples of this and how this plays out in some health-related issues in our teenagers. This slide shows the risk of ADHD related to the interaction of gene and environment, and specifically the DAT1 haplotype and how it interacts with early deprivation. So you can see on the bottom here the age at assessment, 6, 11, and 15 years, and on this axis you see the ADHD score, with the higher score representing more ADHD symptoms. So children who had a high genetic risk and also experienced early deprivation showed this rather marked increase in ADHD symptoms between these time points, whereas individuals who had just the genetic risk or the environmental risk alone, or neither of these risks, stayed down here. So that's an example of how this epigenetics and gene and environment interaction comes out. And I find this one of the most fascinating areas of medicine. And many of these studies use adopted kids to great result and are teaching us about how these interactions occur. Here's another example, the serotonin transport gene and emotional problems in adolescent. Here we have the comparison group, non-institutionalized, and there were 3 different genotypes that were sampled. And on this side, we have children who experienced institutional deprivation for 6 to 42 months. If the child had this genotype, maybe there was a protection against emotional problems, but in this, there's a higher risk for emotional problems. So it all comes together with the gene and the environment working together in ways we are just starting to understand. There are many other studies that look at these kinds of interactions, and some of these conditions, depression, mental health problems, antisocial behaviors, may present in adolescence. So that's why I bring it up in this review of adolescent health. Let's move on to those miscellaneous medical conditions and just see what we can say about them. Anemia is the most common medical diagnosis that we make in our clinic. It's about 70 to 80% of children, and usually this is iron deficiency anemia. Again, most of the kids have no symptoms, but some of them may be irritable, not want to eat, they have decreased alertness, decreased attention span. For a family just getting to know their child, these symptoms may not be completely obvious or easy to differentiate from other things. Later on, the kids may present with learning problems. And this may be even after the anemia has long been corrected, but having that iron deficiency in early life is not good for the developing brain. Here's one study that illustrates that rather dramatically, and this is a group of children who had iron deficiency as infants, were treated, and then were studied at age 19, and were found to have deficits in all these components of executive function, as you see here. We've also found an interesting relationship between anemia and academic outcomes in our teen outcomes studies. We have looked prospectively at 88 teenagers that we saw when they were little kids, when they first came home, and then were able to get information about them as teenagers and young adults. This slide shows the academic success score, which was a derived measure of their grades and achievement scores and other things like that. But the important message is that those who were not anemic at arrival, this is years and years and years ago, had much higher, much better academic success scores than those who were anemic when they first came home. So this is just another emphasis of how a medical problem can impact some of the other issues that children may face. Now, this is an area that's near and dear to my heart because I am a pediatric rheumatologist, so I deal with kids with autoimmune disorders. And one question is, how or does early adversity permanently alter immune function? There's very few studies that really directly answer this, and it's an area that should be investigated in more detail. But one study that came out recently, or not that recently, it came out a while ago, is a study done in Sweden where internationally adopted young men who reported for their military conscription physical were evaluated for the presence of allergic disease. And the researchers asked what the incidence of asthma, hay fever, and eczema were based on the region of origin. And you can see that young men who had been born in the Far East and then moved to Sweden as young children had a higher incidence of hay fever. And more interesting was that this was related to the time the children were adopted, with the younger children having more hay fever and kids who spent more time in their country of origin having less hay fever. Well, you might say hay fever, who cares? Take a Claritin, you'll be fine. But this is a sign that the immune system is being affected and that this lasts a long time. In my pediatric rheumatology clinic, I'm really interested to see the number of kids that come in to see me with autoimmune disorders. And I'm really puzzled by this and would love to understand this better. I don't quite get it, and I don't know that we have a really good registry to see if this is just a little blip because I happen to have these two unrelated specialties, or if there's really something going on. But I have a lot of kids that were internationally adopted that I saw years ago as babies. They're coming into me with arthritis and lupus and some real rare and weird autoimmune disorders. So I'd love to know more about that. Okay, let's talk now about special needs. Now, there's an increase in the adoption of special needs children overall, and there's also the theme of the emergence of special needs, maybe social and academic problems as kids grow up. So these are the two pathways of special needs that we see. And I love to show this picture because this is one of my favorite families from our clinic. This is 5 unrelated children who were adopted by a family in Connecticut, and each of these children has a very, very significant medical special need. I don't know if you can see or notice, but the young lady with the soccer ball in the upper left is missing her right arm. And she just graduated in her top of her class in law school and is a great young woman. And all of these other children in this family have similar significant medical special needs. But this is one group of children that we see a lot, and we're seeing even more because of various political issues in some of the countries of origin. Now, it was interesting to me to find this paper about disability among adoptees. I didn't realize, but in the 2000 United States Census, 2 very important questions were asked that allowed this work to be done. The first question was, each individual in the household is asked about these questions, does this individual have a disability? And then the other question was this individual adopted? And if so, domestic or international? So having those 2 questions in the census allowed these researchers to pull this data out. And you can see the numbers were enormous. There were 82,000 international adoptees, 970-some thousand domestic adoptees. And when the data was analyzed, these 2 groups of adopted individuals of all ages had more than twice the rate of disability than the non-adopted population. The other questions that were asked as kind of a sub-question to those were, what type of disability is it? And for most, it was a mental disability, and that was not defined further. But I think this is really interesting and something we should all know more about. They did make the point in this paper that individuals adopted from China and Korea were in the lower rate of disability, as well as those adopted less than 1 year of age. The last area I'm going to talk about very briefly is functional outcomes, and I'm just doing this to prove to you that pediatricians care about mental health too. We don't just care about physical health. And I'm going to present just a couple of slides on mental health in internationally adopted young adults. These both come from these large registry studies, which I really like because, boy, they get large numbers of people and they really can keep track of data, and it's impossible to replicate that kind of work here. But in the Netherlands and in some Scandinavian countries, they keep these registries of medical diagnoses. And in these 2 studies from the Netherlands, the incidence of anxiety disorder, substance abuse, and mood disorder was increased moderately over the non-adopted comparison population. In this study, which had 11,000 adopted individuals who were living in Sweden, the rate of these problems was definitely increased over the baseline of the non-adopted control group. And it's very concerning when you look at that, but when you look again at the way the data comes out, the authors point out that there were many individuals who had multiple problems. So it wasn't that each of these represents a single individual, but many people had comorbidities. And 85% of this population had no mental health disorders or social maladjustment. So in conclusion, internationally adopted teens and young adults have specific health risks related to early exposures and diseases of long latency. Pre-adoption and post-adoption risk factors relate to outcomes. And again, going back to what Dana and Peggy taught us all these years ago, and we've all used as a model, careful screening at entry and attentive follow-up may help with early identification of problems. So I'll thank you for your attention.
Well, thank you for a wonderful introduction, Laurie. Few people know that Laurie and I are actually twins. We were separated early in our careers, and she came out to Minnesota, but we both came out to Massachusetts, but we both trained at the University of Minnesota, and Laurie was very interested in the adoption clinic there and went out to develop the one at Tufts. We also are kind of twins in the sense that we get paid not necessarily for doing our adoption work, but I'm a neonatologist and Laurie is a nephrologist and rheumatologist. So a lot of similarities, and we've spoken together in the past, and it's always good because I always learn a ton of stuff from you that I have totally ignored in the literature over the years. What I want to talk today about is growth and puberty in particular, and also talk about some of the things that we were brushing on at the end of Laurie's talk about, what does this mean for health issues as these kids get older? The first thing I want to do is talk about growth in children exposed to early deprivation, because I'm going to tell you the same thing that everybody else has told you today, which is what happens to you when you're an adolescent is very, very dependent on what happens to you very early in your life. So we're going to talk about growth suppression and then recovery, and factors determining final height, because every adolescent wants to know how tall they're going to be, and then the long-term risks to health that may be set up or embedded in the individual very early in life and only manifest as we get older. One of the most dramatic things that I remember from my career is walking into a room of a family who had adopted 2 children from Colombia, and they were brothers. One was about 3 years older than the other, and they both were the same size. And I was amazed at the degree of growth stunting, and went out and talked to one of my colleagues who was a pediatric endocrinologist who said, oh, it's probably deprivation dwarfism, which I had never heard of before. This has really become my focus of research over the last few years, and what we can say about most children coming from abroad, and even to some extent children growing up in the foster care system, is that growth is pretty dismal. What we see here is a chart that looks at growth in a standardized fashion. So these are z-scores. So a 50th percentile child growing along the normal middle of the growth curve that you see in your pediatrician's office is going to have a z-score of 0. 1 standard deviation below the mean is -1. 2 standard deviations below the mean is -2. And this defines the normal range, plus or minus 2 standard deviations. So you can see that the kids that arrived early when Romania first opened up, who had come out of institutional care that was very, very terrible, were profoundly growth impaired. This is Michael Rutter's group. This is a group that Laurie and I published that had come to the United States. Since then, things are improved somewhat, and institutional care is not quite as bad as it was, but we can see that most kids wind up in terms of height, which is always going to be in the green, and weight, which is going to be in the yellow, somewhere between 1 and 2 standard deviations below the mean. So these kids are quite short compared to the kids that are their age-appropriate peers in the United States. It doesn't seem to make very much difference what country they're coming from, but institutional care is a situation where we always see impaired growth. Now, those are the children who were chosen to be adopted. So they are a select group that are generally doing better than the kids who stayed behind, and especially the kids who stayed behind for their entire childhood within institutional care settings. So the next data that I'm going to show you are data from children who lived in the worst places in Romania. These are the neuropsychiatric institutes and the Cămin spitals where these children were relegated when the government felt that they were not going to be productive citizens. And you can see that it looks precisely like a concentration camp, because that's what they actually were. When you look at the growth of these kids, and these are the standard growth curves that you would find in your pediatrician's office, you'll find that in terms of height and in terms of weight, the average is far, far below 2 standard deviations below the mean. And in fact, when you get up into the adolescent area where you're not going to find very much more growth. These children are extremely small compared to what you would expect. Now, many of you have seen these slides. I show them all the time. But those of you who haven't seen these slides, you have a little guessing game. All right, I want you to tell me the child that's on this side, how old that child is, and I want you to tell me if it's a boy or a girl. Anyone want to guess? No one wants to guess. Okay, 5 years old. Well, you're right in the sense of how high you would expect, or how tall you would expect a 5-year-old child to be, but this is an 11-year-old girl. Now, you want to try the middle one? Okay, well, 14, and she's a girl as well. What about the child on the right? I want to know if it's a boy or a girl. All right, that's a 17-year-old girl. Not only is she short, but her pubertal development is far, far behind. In fact, we had girls that were 22 years old who were just starting pubertal development within these institutions. So one of the things that I'll talk about is how the timing of puberty has changed in these kids. In the situation where children stay under profound deprivation their entire lives, puberty is delayed significantly, probably about 2 years when you look at the normal curves that you can construct. Now, why are kids growth impaired when they are in institutional care settings? Well, there are a number of potential reasons why there's growth failure. First of all, the available diet. Even though the government says they're getting adequate food, we know from our studies in Kazakhstan that these kids are actually only getting about 50% of the nutrients that they need to grow, because the baby home doesn't make the food the way they're supposed to, and the kids don't have a chance to take it in. The other thing is that there's a very high percentage of low birth weight babies in orphanages, sometimes up to 45% in some studies. And the nutritional requirements of low birth weight babies are very different than full-term babies. And in fact, those kids need about 20% more calories and more protein to grow well. And diets for low birth weight babies are no different than diets for full-term babies with institutional care settings. There's also the ability and desire to feed. There's a phenomenon called hospitalism that was described around the turn of the 20th century in baby homes and especially hospitals. Remember back then, mothers were not allowed to stay with their children. They were there for months at a time, and kids had no interactive care at all. And these kids basically gave up the will to live and stopped eating. The other thing is that children with disabilities make up a very high percentage of kids in orphanages, and cleft lip and palate is one of the most common reasons that we see children institutionalized in terms of congenital malformations. And the caregivers don't have time to spend the time necessary for a child with a cleft lip and palate to actually eat enough. There's also the opportunity to feed. When you have a child at home, and all of you that have taken care of a baby know, as Megan said, they rule the house. They tell you when they want to eat. We respond to their cues. In a baby home, kids eat at 8, they eat at noon, and they eat at 5, period. They can be hungry. None of their needs are met except on a timetable, because you've got a caregiver responsible for taking care of somewhere between 8 and 10 infants, and there is no time to tailor a intervention, any kind of intervention or interaction with the baby other than what's on a schedule. And finally, Laurie mentioned the problem of parasites. Certainly things like Giardia and Helicobacter are organisms that will impair a child's desire to eat and also their ability to absorb. So it's very important to think about that as well. So when you look in terms of a summary of growth suppression within institutional care settings, all growth parameters are affected, height, weight, and head circumference. There seems to be more of an overall suppression of growth rather than a dose-dependent suppression related to deprivation. Now, I'm not saying that, The remaining orphanages where life was horrible, those kids aren't going to grow as well as kind of your average orphanage. But within an orphanage, we found no relationship between the caregiving scores that were kind of on the low side versus those that are a little bit better. They're all low, but there is a range in there, and it doesn't seem to make very much difference in terms of how much growth suppression, how that caregiver treats you within that environment. If you're in a bad environment, it's a hit, and you don't grow particularly well. The other thing is that underlying medical issues will exacerbate this problem. For instance, growth retarded babies are going to be smaller, significantly smaller, low birth weight babies are going to be significantly smaller than full-term babies, again, because they're not getting the calories that they need. Also, children with fetal alcohol syndrome are going to be smaller as well, probably because of abnormalities in their hypophyseal pituitary growth system. Now, the good news is these kids have tremendous amount of catch-up growth. Now, this is a study we did with about 130 Eastern European orphans seen in our clinic and Pat Mason's clinic down in Virginia. What we saw here is when they arrived, and these kids were about 18 months old when they arrived, they had growth suppression in terms of their height and their weight and their head circumference in the range that I was speaking of, about -1 to -2 standard deviation below the mean. 6 months later, they had made significant progress. By the time they were 30 months old, and these are brand new data, they'd completely caught up on average in terms of height and in terms of weight. What's going on with head circumference here, I'm not exactly sure, but in the Bucharest Early Intervention Project, we showed that there really wasn't very much of a significant head growth. And that's probably because that window of sensitivity for our ability to catch up is probably earlier for head size than it is for height and weight. But the bottom line is that in terms of height and weight, the prognosis is pretty good after the kids arrive. When you look at, and again, this is out of the Bucharest Early Intervention Study, if you look at 6-month periods, kids grow very, very rapidly during the first 12 months that they're in their home. And then they kind of stop. There's not a whole lot of catch-up after that period of time. And there are a number of factors that are independent predictors of how well a child is going to catch up after arrival. First of all, the younger the child is at the time of arrival, the better off they're going to catch up. And I'm going to show you a slide in a second to talk about that. Children who are the most growth impaired at the time of arrival have the greatest amount of catch-up growth. Now, growth is a complex and still not well understood process. And this gets to the whole issue of why your child, at a year of age is at the 25th percentile, while they're probably still at the 25th percentile by the time that they enter puberty and adulthood. There's a canalization of growth that occurs for reasons that we're really not quite sure. But once a child gets to that particular point, they usually stay there unless they have something that causes them to fall off their growth curve. So the further a child is behind, the more impetus there is to catch up to that place where they should have been in the first place. So for instance, if a child arrives of a normal size, there's really no reason for them to grow a lot more. So if you're at the 50th percentile when you arrive, chances are you're not going to be at the 90th percentile in 6 months. You're going to be at the 50th percentile. But if you're -2 or 3 standard deviations when you arrive, you're going to grow a tremendous amount during that first year that you're in your adoptive home. A very interesting finding out of the Bucharest Early Intervention Study was that the higher the quality of care that the child received in the foster home, the better their catch-up growth was. And it wasn't all kinds of care. It was 2 specific areas. One was positive regard for the child, that the caregiver actually liked that kid. And the second was how sensitive that child is. So the whole issue of interaction, how the caregiver and that child form that bond is extremely important in this basic biologic issue of catching up in terms of growth. The other thing, and how many of you have adopted? All right, how many of your kid ate more than you could possibly imagine when they first arrived? It is absolutely true. We looked at dietary logs of these kids after they arrived. during that first 6-month period. Some of the kids were eating 3 times what children of their age would normally eat. I had, I'm sure Laurie can tell you the same stories of parents coming in and the mom saying, I can't believe it, my 3-year-old is eating more than his father is. Really enormous amounts. And it gets to be a problem sometimes because we have upper middle class families who are very weight conscious and very fitness conscious about their kids, and they're afraid they're going to get obese. So there's a lot of pathology that develops during this period of time surrounding food and how free children are to eat during that period of time. Who lags behind at 6 months? Well, obviously the kids who are most growth suppressed. They have more potential growth to do before they get up to on the growth curves they're going to be. Older children, and again, this is an age phenomenon that I'll talk about in a second, but I want to add another bullet point here that Laurie reminded me of. We don't have any data on this, but anecdotally, when the kids would come back for their follow-up visit and weren't catching up, more likely than not, they were the kids that were colonized with Helicobacter. And treating the Helicobacter in and of itself often promoted growth in those kids. So, Megan showed some absolutely beautiful slides, which I want to steal from her this morning when she talked about kind of sensitive periods when we see proliferation of brain development. We talked about the early of hearing and vision synapses, others of speech, and others of cognition. And there are some, not that the door ever closes, but there are sensitive periods of time when we get more bang for the buck of putting a child into a more nurturing environment. And we see the same kind of thing in growth. Now, growth is nice because you don't have to biopsy the brain to figure this out. You can actually watch this happen. So this is a growth velocity curve. So these are for normal kids. And we can see that early in life, this is height. So early in life, we see a great deal of growth. This is a growth velocity of 25 centimeters a year. When we drop down to about 6 years of age here, we're down to a very, very low growth rate. And what happens in the adopted kids? Well, they're all above, or most of them are above the 95th percentile. So they're growing much, much faster than children their usual age. But it goes down with time. So if you adopt a child who is 18 months of age, they're going to be up here growing about the same rate that a child during the first year of life is going to be growing. But if you adopt that child at 5 years of age, they're still going to be above the growth rate that a normal 5-year-old would be, but it's going to be much less than it is here. So there are windows of opportunity for recovery, and I think growth shows us that as well as anything does. What about long-term recovery? So growth early on is pretty good. Kids are going to catch up during childhood. So this is the Minnesota International Adoption Project that Megan was the principal investigator. And what this is the reported height and weights of kids at various ages after adoption. So we can see here kind of what we've seen early on, that height and weight kind of catch up, but something happens here. And suddenly we start seeing these kids, they're not shrinking, but in proportion to the kids of their biologic age, they're shorter and they're lighter. Okay, Michael Rutter showed the same thing in his population. They had 3 points at 6 years, 11 years, and in mid-teens. And they saw the same thing, that these kids were short early on. By 9 years of age or 11 years of age, they had basically caught up. And by their mid-teenage years, they were down in this area too. Well, what happened? All right. First of all, I want to dispense with a common preconception of parents that their child is small because their biologic parents were small. Indeed, if you go to many countries where the children come from, these parents are going to be smaller. But I want to remind you of the phenomenon of the immigrant groups. When in Minnesota, not only do we have a lot of international adoptions, but we have a ton of immigrant groups that come in. And we have Hmong, we have Vietnamese, whatever. And parents arrive with their kids as young children. And the parents are very, very short. But their kids get very, very tall. They're always bigger than their parents. Because the reason that most parents are short in countries of origin, and again, there's obviously genetic differences in how tall people will be, but they've been malnourished. They've had chronic stress. They've had lots of infections. And when the kids come to this country, they don't have that as much. They don't have the same degree of chronic stress of war and conflict. They don't have the chronic stress of childhood diseases because they're immunized, and they get much, much better nutrition. So you see families that have been here for a while, and grandma and mom and dad, it's you know, grandma's down here, mom and dad are here, and the kids are up playing on the basketball team. So it's not parental height. It can have some influence, but it's not the reason that their child is going to be small. There are three reasons. One is you can have prenatal growth impairment. Again, most of the women who relinquish their children have not had the opportunity to have good prenatal care. These fetuses are often smaller. And if you are a growth impaired child, especially a very growth impaired child, that will have a major effect on how tall you are later on in life. Postnatal growth impairment, such as being in an institution, takes its toll. Yes, there's catch-up growth, but as Megan talked about so nicely this morning, you're shifting that bell-shaped curve to some degree. So the kids who would have been 6'3" tall, maybe are going to be 6 feet tall now because of that combination of prenatal and postnatal growth impairment. What I want to talk about in terms of adolescence is the concept of early, or the phenomenon of early puberty. And this is a disorder that particularly affects girls. Now, this is sometimes gets to be a very emotional issue, particularly with adoptive moms, to think about having their child go into puberty very early. So it's easy to talk about sex and have people pay attention and not fall asleep. Sex hormones are important throughout life. It's not just puberty when this is important. And in fact, for boys, it's critically important during development, because the secretion of testosterone and the action of testosterone on cells actually makes you a boy. The default situation in development is that you become a girl if you don't have testosterone. If you do have a normal response to testosterone, a normal production of testosterone, you develop male genitalia. Otherwise, you wind up with uterus and vagina instead of a penis and testicles. And it's active also, the sex hormones are also active during the first year of life. Some of you may have had a little baby girl who actually was making milk because their breasts were large. That's because of the persistence of not only maternal hormones, but the action of hormones that are made by a baby's ovaries. But most of the time we think about sex hormones acting is at the time of puberty. Now, I showed you the slide of growth velocity and height. We have two actual surges in growth. One is during that first few years of life where growth velocity is very high. The other is during puberty. So those are the things that determine how tall you're going to be, is your initial growth and then your pubertal growth. Now, there are differences in puberty, obviously, between boys and girls, but the point I would make here is that the control of puberty in girls is much less closely controlled by the body than the puberty in boys. Early puberty is about 10 times more common in girls than in boys. And while we do see international adoptees that are male enter puberty early, it's very, very uncommon. Almost all the literature is on females. One of the problems is deciding what actually is precocious puberty. and there are many different ways of defining that. For the most part, pediatric endocrinologists in this country will say that less than 8 years for girls, less than 9 years for boys is a little bit early. Now, there had been a number of case reports of early puberty in girls, and there were a number of hypotheses rendered about why girls went into puberty early. Was it the fact that they were exposed to toxins in their country of origin? Or what was actually the cause of it? And some of the reports have stated that the amount of catch-up growth was related to earlier puberty. So the girls that had the most catch-up growth were the ones that went into puberty the earlier. There was a lovely study that came out in 2009. And again, using a database like Laurie mentioned in the Scandinavian countries where we have huge public health services that render care to everybody, perhaps unlike what we're going to have in the United States in the near future. But they went back in Denmark and looked at early puberty in Danish girls versus international adoptees that had come to Denmark. And what they found was that there clearly was a difference in the age of puberty. Now, these are probability curves. And what this basically means is when you go up here, there's a 50% probability that you would enter puberty, so that would be the average age. So in Denmark, in Danish-born girls, in terms of breast development, which is the first stage in pubertal development in girls, it's about 10.8 years. Now, this is a very, very similarly shaped curve, but it's earlier. And what we see is that the onset of breast development is about 9.5 years, or about 1.3 years earlier than it is in Danish-born girls and international adoptees. And also, the onset of menses is 1.3 years earlier. It doesn't appear to be quicker because the curves are still the same shape. And there are other couple of observations that were very interesting. One was that they looked at the country breakdown of early puberty, and they saw that all the countries were about the same in terms of early puberty except for one, and that country was Korea. And why was Korea different? Well, Korea uses foster care. So the environment of that child was better. That's the way I would interpret it. And otherwise, they're coming from a more stressful situation. Another study that was done around the same time was looking at precocious puberty in Spain in international adoptees and domestic adoptees. And they found that in domestic adoptees, they had the same high risk of early puberty for girls that the international adoptees had. So it's not the international adoption, it's the kids who have probably sustained early stress. There are treatments for early puberty. There are a couple. One is Depo-Lupron, which is a drug you administer once a month. It's an injection, and it suppresses the hormones released by the hypothalamus that start the whole pubertal process. You can also use a long-acting little plastic rod saturated with another drug that will also inhibit puberty. It's very successful in stopping central puberty. It's expensive. Some insurance companies will pay for it, some will not. And it buys additional years of childhood. And not only does it help prolong the period of growth before puberty, it increases the height that these children will have later on in life, because the longer you go before having your pubertal growth curve, the taller you will be. And it does improve height when it started early, for very early puberty. Whether or not it's worthwhile doing for an 8 or 9-year-old is another question. But also for international adoptees, we have to think about the social age of the child, and it's very important that that child be able to take care of themselves and to be able to socially deal with the issue of early puberty as well. let me talk a little bit about some of the parallels in kind of the early experience and what we see with the onset of disease later on in life. We have a parallel here in terms of small for gestational age babies who we know have growth impairment early in life, impaired growth hormone sensitivity. They do have catch-up growth. We have early puberty, especially girls, abnormalities in cortisol secretion. And we know from following these kids for some time that they are a very high risk for a metabolic syndrome, which includes obesity, type 2 diabetes, hypertension, and cardiovascular disease. What about institutionalized kids? Well, there's really direct parallels. They have all the same thing. So the question is whether or not our international adoptees will also be at risk of the metabolic syndrome. And I'll show you something in a minute. This gets to the whole issue of stress in early life and later disease in adulthood. And there have been a number of studies done over the last 15 years that have looked at that in a variety of ways. Cross-sectional studies, meta-analyses, and actually longitudinal follow-up of kids. This was one of the first ones that came out, looking at a cross-sectional study of over 13,000 adults in Kaiser Permanente health system in Southern California, and found that if individuals were exposed to 4 or more of these early stressors, this was the risk of these various conditions later on in life. So this is a 7.4. These are odds ratios. These are increases in the odds that individual will have problems. So what happened to you as a child had major impact in terms of how they did later on in life, not only for risk behavior, but also for adult disease as well. In terms of adolescents, they also published a separate paper looking at the risk of unintended pregnancies with these early childhood stressors, and found that the risk of unintended pregnancies was higher as well, not necessarily in adolescence, but anytime. So adverse childhood experiences led to social, emotional, and cognitive impairment, adoption of health risk behaviors, disease, disability, and social problems, and early death. So that was their conceptual framework. Megan mentioned the whole issue of allostasis and allostatic load. We know that there are not only social problems that occur with individuals who have sustained early life stressors, but we know that there are actual alterations in the brain when those homeostatic mechanisms become overwhelmed during early life. Not only in the brain, but the HPA axis, and also in the immune system. We have elevated inflammatory levels that Megan was just mentioning, as well as altered responses to infection. A large meta-analysis looking at over 40,000 individuals found increased risk of a variety of adult diseases, much the same as what we've talked about. But perhaps the one study that is most applicable to children who have sustained the kind of early stress that we're talking about, which is really early neglect, was done in New Zealand. And what they did was they followed these kids for 32 years, so a very, very nice longitudinal study. And they looked at maltreatment, or children who were maltreatment, children who were socially isolated, and also children who were growing up in poverty. And the two groups that seemed to have the greatest sequelae of the early stress were the kids who had maltreatment and social isolation. So they were much more likely to be depressed. They were much more likely to have high inflammation levels as measured by CRPs. And they were much more likely to have a cluster of metabolic factors, 3 or more of the factors that you read up there. So clearly, children who had been neglected early on in life had the basic foundation of a number of adult diseases that I've mentioned. What about international adoptees? Well, the only marker that we can look at is height and weight in late teens. Now, if you look at you calculate the BMIs based on this, they're not outside the normal range, but we can see these kids are shorter than they're lighter. So these kids have more fat on their body. They weigh more than they probably should for their height. So I think this is a really fruitful area for investigation, is to look at some of these markers, the inflammatory markers, the disease markers, as Laurie's talking about, the immune disorders that she's seeing in her clinic, and also at the risk factors for cardiovascular disease and type 2 diabetes as these kids are getting older. The last thing I want to talk about is telomeres. Telomeres are specialized areas on the chromosome that help stabilize DNA. Every time our DNA divides and replicates, the area of telomeres on the end of the chromosome shorten a little bit. Okay, so we can actually kind of get an idea of how healthy that chromosome is by looking at the number of telomeres that we see down there. The bad thing is that when the telomeres go away, your cell no longer divides. It enters senescence and eventually dies. So that's a bad thing. We like to have our cells continue to divide, to replicate, and to heal things within our body. But we know that accelerated telomere shortening occurs in a variety of stressful situations, both biologic stress, such as cigarette smoking, radiation exposure, but also in psychological stress. Now, this has been done primarily in adults, where we have gone back, asked them if they've had psychological stress early in life, and looked at the length of their telomeres and found that those who are stressed are shorter. And it hadn't been done in children until the Bucharest Early Intervention Project. What they found was the same thing that you see in adults, is that the more stress that a child sustains, the shorter their telomere length is going to be. So it was a little bit different in males and females. We're not exactly sure how to explain that. But the length of time that the children had been institutionalized prior to getting out into a foster home, capable foster home, was related to the length of their telomeres. So the kids that were stressed had shorter telomeres and presumably are at higher risk for adult-related disease. The last slide I would like to say is that you can sit there, and I've got a 26-year-old adopted kid, and I'm worried. Is he going to develop type 2 diabetes? Is he going to have cardiovascular disease? I'm lucky because he decided to be a personal trainer, so it's occupationally necessary for him to be in good shape. But as adoptive parents, we want to know, are our kids really at risk of these issues? Well, I think it's going to be a story like Megan told us this morning, is that it's good news and bad news. The fact that a child comes into an adoptive family has an enormous benefit for them. First of all, the period of stress will end, or presumably will end. Second of all, that family will be there to help modulate the behaviors that child is going to learn and adopt when they are an adolescent. Third, they're going to get reasonably good health care. We found that 99% of our families who adopt in the Minnesota Adoption Project had good health care. So there is that potential of us helping our kids modulate some of these changes, and hopefully the ones that may be able to be more open to change during adolescence, that will prevent them from developing these kinds of issues. So I'm optimistic that we're not going to see the same kinds of magnitude that we're seeing in other situations. But it's something that we have to be very vigilant about. And as healthcare providers, change the behaviors not only of pediatricians, but also of our colleagues in internal medicine who will be following these individuals well into their adult life. We'll stop there, and I think Laurie and I would be happy to answer any questions now.